Hello everyone and greeting to all. My name is Dr. Irfan Ahmed, working as a medical lecturer in Microbiology, Virology and Immunology Department of the Samarkand State Medical University. So today our topic is airborne infectious diseases like diphtheria, pertussis, Mycobacterium tuberculosis and Mycobacterium leprae. So we will discuss one by one and we will start with the topic of diphtheria. So diphtheria as an introduction. What is diphtheria? The diphtheria is a acute infectious disease caused by the toxogenic strain of the Corynebacterium diphtheriae. Three major clinical types: anterior, nasal, facial and laryngeal. So skin, conjunctiva, vulva and other parts may be affected. Bacilli multiply locally in throat and produce the powerful exotoxin. The history took its name from the Greek word diphtheria, means leather. Name in 1826 by the French physicians Barry Bretigneau. In the past, disease was called as a general disease or the killed disease because there was no treatment and was a cause of the high mortality in children. It was said that the disease killed as many as 80% of the children below the 10 years. Words: developing countries, rare disease due to the routine child vaccination. In developing countries, endemic due to the lack of adequate widespread immunization. Reported case in 2010 is 4,187 active cases. So epidemics are the largely due to the decreasing immunization coverage among infant and the children. Warning: immunity. The waning immunity to the diphtheria in adult is movement of the large group of the population in the last few years and irregular supply of the vaccines. The agent is Corynebacterium diphtheriae, gram-positive motile organism, non-invasive power but produce powerful exotoxin after multiplication locally in the throat, responsible for formation of the false membrane over the tonsils, pharynx or the larynx with the well-defined edges and the membrane cannot be widespread. Marked congestion, edema, local tissue destruction, enlarged of the lymph node, toxemic sign and symptoms. Four type is Graves, mitis, Belfanti and intermedius. The Graves more severe than the mitis infection. The sensitive to the penicillin and rarely killed by the heat and the chemical agent. Affect the heart, myocarditis and nerve paralysis. Source of infection. The cases range from the subclinical to clinical. Mild to silent infections may be exhibit none more than be running nose from the sore throat. Carrier state, common source of infection, may be temporary or the chronic nasal or throat carriers. Nasal, dangerous, frequent shedding into the environment. Temporary, last for the 1 month. Chronic, last for the 1 year until the patient is treated. Infective material, nasopharyngeal secretions, discharge from the skin lesions, contaminated vomitus and infected dust. The period of infectivity 14 to 28 years from the onset of the disease, but carries may be remain ineffective for the much long periods. In case of the carrier may be considered non-communicable when at least 2 cultures obtained from the nose or the throat. When at least 2 cultures obtained from the nose and throat 24 hours apart are negative for the diphtheria bacilli. Host factors. Age children up to the 1 to 5 years, sex both, immunity infant born of the immune, mothers are the immune for the first few weeks and the month of the life. Environmental factor, cases occur in all seasons, winter favorable, Kolkata highest incidence in August, Mumbai in a winter month and Delhi August or October. Mode of transmission, droplet infections can also be transmitted directly to the susceptible persons from infected cutaneous lesions. Transmission by object contaminated by the nasopharyngeal secretions of the patient is also possible. Portal of the entry, respiratory route, respiratory tract. Non-respiratory route is a portal of entry, may be skin where the cuts, ulcer and wounds not properly attended to throughout the umbilicus of the newborn. Site of implantation may be eyes, genitalia or the middle ears. Incubation period 2 to 6 days, occasionally longer. Clinical features, respiratory tract from the diphtheria, pharyngotonsillar, laryngeotracheal, nasal combination. Pharyngotonsillar diphtheria, the sore throat, difficulty of the swelling, low grade fever at presentation, the presence of the pseudomembranous over the tonsils, edema in submandibular region, bull-necked appearance. You can see in the pictures is a laryngeotracheal diphtheria proceed by the pharyngotonsillar diphtheria. Fever, harshness of voice and crappy cough is dyspnea. The toxic damage is the parenchymatous degeneration, necrosis in the heart, muscles, liver, kidney and adrenals. Vision difficulties, speech, swallowing or the movement of the arms or the legs, paralysis of the soft palate, eye muscles or the extremities. Nasal diphtheria, mildest form, localized in the septum and turbinate of the one side of the nose, conjunctiva and the genitals also the source of the infection. Membranous extend to the pharynx. Cutaneous diphtheria, common in the tropical areas, secondary infection of the previous infection or skin abrasions. The presenting lesions and ulcer surrounded by the erythema and the covered with the membrane. 10 years boy with the severe diphtheria, conjunctivitis, pharyngeal membrane, bull neck, severe myocarditis. Schick test. What is Schick test? Schick test is intradermal test of the presence of the antitoxins, immunity status and state of the hypersensitivity to the diphtheria toxin. Inject 0.2 ml of the Schick test toxins intradermally into the skin of the forearm, while into the opposite arm. Control Schick toxins inactivated by the heat is injected. Negative reaction if the person is immune, no reaction of any kind. Positive reaction in test arm is circumscribed red flash of the 10 to 50 millimeter diameter appears within the 24 to 36 hours, reaching minimum development by the 4th to 7th day. This slowly fade into the brown patches and the skin desquamatus. Control arms show the no changes. The person is susceptible to diphtheria. Pseudo positive reaction, a red flush develops equally on the both arms, much less circumscribed than the true positive reactions. Fade by the 4th day. Allergic reaction found in the certain individuals. Schick negative. Combined reactions. The control arm show the pseudo positive reactions and the test arms show the positive reactions. The person is susceptible to the diphtheria. Control of the diphtheria, causes and carriers. early detection, start active search, enter immediately from the family and the school contacts. Carriers can be detected by the culture method, swab taken from the nose and the throat. Isolation, all cases, suspected cases and carrier should be the isolated, preferably in a hospital for at least 14 days or until the proven free of infection. Two consecutive throat swab taken 24 hours apart should be negative before the terminating isolation. Treatment case, primarily test done of the 0.2 ml subcutaneously to detect the sensitization to the horse serum, followed by the dip antitoxin IM or IV in the doses ranging from the 2 to 20,000 to 40,000 unit per or more depending on the severity of the cases. Mild early pharyngeal or laryngeal 20,000 to the 40,000 international unit. Moderate nasopharyngeal 40,000 to 60,000 units. Severe extensive or late disease 80,000 to the 1 lakh units. Addition to antitoxin, the penicillinor and erythromycin for the 5 to 6 days to clear the throat. Carrier should be treated into the 10 days course of the oral erythromycin. The contacts should be throat swabbed and immunity should be determined. Where the primary immunization was received within the previous 2 years, no further vaccination and action needed. Where the primary course or the booster dose of the diphtheria toxoid was received more than the 2 years before, only a booster dose of the diphtheria toxoid need be given. Non-immunized close contact should be received the prophylactic penicillin or erythromycin. They should be given the 10,000 to the 2,000 unit of the antitoxins and actively immunize against the diphtheria. So diphtheria immunization. Combined vaccine is a DPT, DTPV and DTPA, DTB tetanus toxoid, diphtheria tetanus adult type. Single vaccine is a formal toxoid, alum precipitated toxoid, purified toxoid, aluminium precipitate, hydroxide, toxoid, antitoxin, flocculus, the anti-series diphtheria antitoxin. DPT vaccine for the immunization of the infant, pertussis component, enhance the diphtheria toxins, type plain and adsorbed. Absorption carried out of a mineral carrier like aluminium phosphate or hydroxide. Storage should be frozen, stored in refrigerator at 2 to 8 degrees Celsius. We lose the potency of the keep at room temperature for a long time. Optimum age. Global Advisory Group of EPI extended program of immunization recommended that the DPT and be safe administration as a early 6 week of the birth. Dose 3 dose of the DPT each 0.5 ml. Mode of admission. All vaccines contain the minerals carrier should be injected. Intramuscular DPT given in upper and outer quadrant of the gluteal region. Immunization schedule is 6 week, 10th week, 6th, 10th and 14th week, and 6 to 18 month is a booster dose and 5-year is a detrosit booster dose. Reactions: fever and mild local reactions. 2 to 6 develop fever of 39 degree or the higher. 5 to 10 experience swelling and induration. The neurological encephalitis, prolonged convulsions, infantile spasm, Ray's syndrome. Contraindication: seriously ill children or who need hospitalization are not vaccinated. should not be repeated if a severe reactions occurred after a previous dose. In case of DPT, subsequent DT immunization. So next disease is pertussis. The pertussis is also called the whooping cough, pertussis, intense cough, and highly infectious disease. Etiology is the Bordetella pertussis, B. parapertussis, and B. bronchiectasis. Epidemiology worldwide 1922 to 1948 leading cause of the death. Endemic epidemic circles. Extremely contagious, attack rate is 100%. Immunity is never completed. Protected begin with wane in 3 to 5 years after vaccination. Unmeasurable after 12 years. Adolescents and adult are the major reservoir. Age 1 to 5 years. Incubation period is 7 to 10 days. Infectivity first 4 weeks. Transmission by the droplets. Pathophysiology is a B. pertussis produce many biological active substances. Inflammation of the respiratory mucosa, patches necrosis, tenacious mucopurulent exudate, bronchoalveolar obstruction, atelectasis, bronchiectasis. Clinical feature B. pertussis is a 6-week disease, cathedral stage 1 to 2 weeks, non-specific features, congestions, rhinorrhea, sneezing, lacrimation, conjunctival redness, low-grade fever, mild cough, paroxysmal stage 2 to 4 weeks, cough in first dry and intermittent, inexorable paroxysm, machine gun burst of uninterrupted cough, series of the coughing in a single expiration, eyes bulging, watering, chin and chest held forward, tongue protruding maximally. Paroxysmal stage is 2 to 4 weeks, is a cough in a first dry and intermittent, inexorable paroxysm. Machine gun burst is uninterrupted cough. The face red blue, whoop at the end of the paroxysm. Post tissue immersive. Post-tussive emesis, numbers and severity of the paroxysm progress over the days to weeks. Infant who are the less than 3 months, no classical stage, well appeared. Infant began to the choke, gasp and flail extremities, redness, face, cough may not be prominent, whooping infrequent. Immunized children have the shortening of the all stages. Adults have no disintact stage. Number and severity of the paroxysm progress and remain at the plateau. Physical examination is unremarkable. Convalescent stage is 1 to 2 weeks. Episode of the cough become the less frequent, less severe. Paroxysm of the whooping disappear. Diagnosis is a clinical diagnosis, paroxysmal stage. Suspect if the predominant complaint is a cough, especially following or absent. Fever, malaise, myalgia, rash, sore throat, hoarseness, tachypnea, wheezing, crepitations. Investigations, blood count. Absolutely lymphocytosis is 15,000 to the 1 lakh cells per micrometer. Fluorescent antibody staining. Culture is nasopharyngeal aspirate. X-ray of the chest. The complication is a respiratory complication, sequelae of the forceful cough and CNS. The respiratory complication is apnea, bronchopneumonia, atelectasis, bronchiectasis, emphysema, interstitial and subcutaneous. Otitis media, reactivation of the quiescent tuberculosis, sequelae of the forceful coughing, epistaxis, subconjunctival hemorrhage, intracranial bleeding, rectal prolapse, umbilical hernias, dehydration, malnutrition, tetany. CNS is a convulsions, hypoxemia, hemorrhage, and encephalopathy. Encephalopathy. The treatment. The treatment is a specific treatment is erythromycin 40 to 50 milligram per kg per day for the 1 to 14 days. Clithromycin 15 milligram per kg for 7 days. Azithromycin 10 to 15 milligram 10 15 milligram per kg for 5 days. Ineffective if given is paroxysmal stage. General measures: young infant should be hospitalized, adequate hydration, nutrition, oxygenation, gentle suction. Cough syrup have no role. Prevention: pertussis vaccine is a part of the DPT vaccines. All household contact should get erythromycin for the 14 days. Close contact less than 7 years should be get booster dose. If documented pertussis infection, exempt from routine pertussis vaccination. So let's move to the very important disease is Mycobacterium tuberculosis. The Mycobacterium tuberculosis is a genus within the order Actinomycetes with the complaint a large number of the well-characterized species, several of which are measured with human and animal diseases such as tuberculosis and leprosy. Aerobic bacilli, non-spore forming, non-motile, non-rod shape, cell wall rich in lipids, acid fast bacilli. The very slow growing. Culture of the M. tuberculosis is it include non-selective and selective media. There are three general formulation that can be used in the both media is a semi-synthetic agar media, insippressed eggs media, broth media. Mycobacterium tuberculosis is a bacterium that causes the tuberculosis. M. tuberculosis has usually waxy wall, is slow growing and among the most reluctant bacteria to treatment. Thin straight rods 0.4 by the power of the 3. On artificial media, cocoid and flaminids form are seen with the variable morphology from the one species to the another. Cannot be classified as either gram positive and gram negative. The Ziehl-Neelsen technique of the staining is employed for the identification of the acid fast bacteria. So this is a classic picture of the Mycobacterium tuberculosis. The constituents of the tubercle bacilli. The constituents listed below are the found mainly in the cell wall. Mycobacterial cells wall can include the delayed and hypersensitivity and the some resistance of the infection. Protein and lipids, mycotic cells, waxes and phosphatides. Protein include the tuberculin sensitivity and polysaccharides. Pathogens, inhaled aerosols engulfed by the alveolar macrophages. Bacilli that replicate, macrophages die. Infected macrophages migrate the local lymph node, develop the Ghon's focus primary complex cell mediated immune response, stop cycle of destruction and spread the variable bun non-replicating bacilli present in the macrophages. Primary interaction, the primary interaction of the type of the TB. When a host was the first contact with the tubercle bacilli, the following features are: acute exudative lesions develop and rapidly spread to the lymphatics and regional lymph node. The exudative lesions in the tissue often heal the rapidly. Lymph node undergo the massive cassations which usually the calcifies. The tuberculin test is become the positive. The primary infections, the involvement may be any part of the lungs but is most often is a base. Reactivation type of the TB. The reactivation of the type of the TB is usually caused by the tubercle bacilli that have the survived in the primary lesions. Reactivation tuberculosis is characterized by the chronic tissue lesions, the formation and tubercle cassations and the fibrosis. The regional lymph node are only slightly involved and they do not caseate. The reactivation type almost always begin at the apex of the lung where the oxygen tensions is high. The difference between the primary infection and reinfection are the reactivation are the attributed to the resistance and hypersensitivity induced by the first interaction. So symptoms of the tuberculosis is primary pulmonary tuberculosis, structural abnormalities, tuberculosis pleuritis is the chest pain, cough with the increasing mucus, cough up to the blood. The common site is meninges, lymph nodes, bone and joint sites is genitourinary tract. Diagnosis is specimen, fresh sputum, gastric washing, urine pleural fluids, cerebrospinal fluid, joint fluid, biopsy material, blood and other suspected materials. Smear as a sputum exudate or other material is examined for the acid-fast bacilli by the Ziehl-Neelsen staining. Stain of the gastric washing and urine generally are not recommended because the prophylactic membrane may be present and the yield of the positive strain. Fluorescence microscopy with the rhodamine stain is more sensitive than the acid-fast stain. If fast acid organisms are the found in appropriate specimen, this is the presumptive evidence of the mycobacterium infection. Interpretation of the tuberculin test. A positive tuberculin test indicate that an individual has been infected in the past. If does not imply the active disease or immunity to the disease is present, the tuberculin positive person are the risk of the developing disease from the reactivation of the primary infections, whereas the tuberculin negative person who have never been infected are not subject to the risk throughout they may become the infected from the external source. Treatment. Anti-tuberculin tuberculosis drug is isoniazid, rifampicin, ethambutol, parazinamide, multi-drug resistant tuberculosis. The next disease of the airborne is Mycobacterium leprae. What is leprosy? It is a disease of historical importance, world oldest record disease, first described as a kushta in Indian ancient texts Shushruta Samhita in 600 BC, stigmatized disease. Gerhard Henrik Armour Hansen discovered Mycobacterium leprae, hence leprosy is called the Hansen disease. First bacterium to be identified the capable of the causing of the human disease cannot be cultivated on the culture media. More than 6 to 8 million cases of leprosy worldwide, 60% of the which are in India. Leprosy is a chronic infectious disease caused by the Mycobacterium leprae and acid fast and rod shaped bacillus. It mainly affects the skin, peripheral nerves and mucous membrane of the respiratory tract. It has left behind a terrifying images in the history and human memory of the multinations, rejections and exclusion from the society. Morphology. They are acid-fast bacilli arrange the signal in parallel bundles like rolls of the cigarette in the packet or in glomerular mass, appear as a straight or curved roll, size in 1 to 8 microns, less acid-fast than the tubercular bacilli. Live bacilli strain uniformly and appear solid. Dead bacilli appear as a fragmented with the granules. Intracellularly, they appear as a bundle of the bacilli bound together by the lipid-like substances, the glia. These masses are known as a globi. Parallel rows of the globi present as a cigar bundle appearance. The cultivation. The M. leprae is found only in the case of the human infection. They have not yet been grown in iron, artificial media or the tissue culture. The generation time of the leprae bacillus is found to be the 12 to 13 days on average. When ground tissue or the nasal scraping from the Lepromatous leprosi containing lepra bacilli are the inoculated intradermally into the foot pad of the mouse and kept at the low temperature, a granulomatosis lesions develop at the site of the injection in the 1 to 6 month. When 9-band armadillo is inoculated with the lepra bacilli, the generalized infections developed with the extensive multiplication of the bacilli. The structure of the Mycobacterium leprae is a lipoprotein membrane, metabolites, ribosomes, soluble protein and DNA and soluble RNA. The cell wall was the characteristic phenolic glycolipid. The carbohydrate antigenic determinant has been synthesized. The triglyceride bind to the basal lamina of the Schwann cells. Resistance variable viable for the 9 to 16 days in the warm humid environment, in moist soil for the 46 days, direct sunlight for 2 hours, ultraviolet light for the 30 minutes. A chronic granulomatosis disease primarily involves the skin, peripheral nerves, nasal mucosa. Incubation period 3 to 15 years. Source of infection, nasal discharge and skin lesions. The portal of the entry, inhalation of the infectious aerosols through the skin contact, damage skin and prolong the closer contact with the infective patients. Principal target cells, Schwann cells, is resulting in the nerve damage, causing the manifestation of the leprosy, anesthesia and muscle paralysis. Classification. The lepromatous tuberculoids, dimorphic or borderline or intermediate. Type of the disease is a reflection of the immune status of the host. Delayed hypersensitivity determine the response of the host to infection and production of the clinical type. The lepromatous and the tuberculoid are two extreme or polar form of the leprosy. Lepromatous leprosy, CMI is absent or the deficient. The tuberculoid leprosy, CMI is intact. Intermediate between the two can acquire any form. The borderline lesions clinically resemble the tuberculoid leprosy, but the bacteriologically resemble the lepromatous type. Therefore, the clinical type of the leprosy is not permanent and changes with the chemotherapy and alteration in the immune status of the host. The clinical feature lesions are the large, diffuse granulomatosis and multibacillary. Diffuse sensory nerves involved and the patchy anesthesia is common. The facial disfigurement is commonly observed. Result is leonine facies, lion-like faces. The patients are the energetic and lepromanic. Characteristic of the clinical form. You can see the typical lesions from the lineal phase of the lepromatosis leprosy. Tuberculoid types. The localized from the disease and the seen in the patient with the high degree of the resistance. The CMI is intact and lepromine test is positive. Skin lesions are few and sharp demarcated. There is early neural involvement which is lead to the deformities in the head and feet. The bacilli and scanty in lesions. This is known as a pubacillary disease. Characteristic of the clinical form. Tuberculoid leprosy is well defined armor erythemoid plaque on the dorsum of the hand. Tuberculoid leprosy. Interminate type. There is a early unstable tissue reactions not characteristic of the either lepromatosis or the tuberculoid types. Lesion heal spontaneously in some persons and in other it may progress with the lepromatous or tuberculoid types. Reedley and Jopling classification based on the clinical, histopathological and immunological finding. Reedley and Jopling classification spectrum of the leprosy into the 5 years. First is tuberculoid, then borderline tuberculosis. Third one is borderline and borderline lepromatosis and lepromatose. So next you can see the lepromin test, which is erythema nodus leprosum inflammatory nodule in the upper limb. Even in the reaction biphasic reactions, early and Frenzen's reactions, erythema and induration of the 10 to 30 millimeter diameter appears 24 to 48 hours, remaining the 3 to 5 days. Like tuberculin reactions, little significant. Diagnosis of the leprosy. The diagnosis must therefore be made by the doing a biopsy in which a small piece of the skin is taken and analyzes for the leprosy bacterium. The early diagnosis is a very important because it can prevent the permanent deformities and disability. For routine examination, these specimens are collected from the nasal mucosa, skin lesions and ear lobules. Specimens: the nasal smear, skin smear, slit skin smear, nerve biopsy. The microscopy diagnosis consists of the demonstration of the acid fast, bacilli in the lesions. Smear are stained by the ZN staining technique. 5% sulfuric acid is used as a discolorized. Third one is culture. Mouse foot pad or medillo. Serology, detection of the antibody against the Mycobacterium leprae, phenolic and glycolipid antigen is a specific diagnostic test. Treatment of the leprosy. Multi-drug regime. Pubacillary lesions, rifampicin 600 mg once month, dapsone 100 mg per day for 6 months. Multibacillary lesions is a rifampicin 600 mg once month, dapsone 100 mg per day. Clofazamine is a 50 mg per daily and continue for the 2 years. Multibacillary lesions is a rifampicin 600 mg, dapsone 100 mg per day, clofazamine 50 mg per daily and continue for the 2 years. Other drug of the leprosy is ethinomide and prothionamide. Thank you very much. This slide and airborne disease are going to end and we will meet in the next video. Goodbye to all.